Hi, I'm Danielle Matias here at Caring Medical Florida with my special guest, Dr. Ross Hauser, our medical director. Today, talking about rib and chest pain, which we were actually just talking about, is something that I didn't really see a lot of when I first started doing prolotherapy years ago. But this is something probably in the last year, like the amount of cases I've had with this has been a lot higher than it normally is. And actually, one of my most recent cases for rib and chest instability was you. How you doing?
Well, you know, I was actually in a patient room, and you know how I like get a little bit animated.
No.
So literally, I went like this or something really quickly, and I heard something crack or crunch, and maybe that's one of the things people when you know, it actually isn't supposed to crack or crunch. The symptom that I had, it wasn't even like here; it was like way over here. And then I couldn't sleep because I normally sleep on my sides, not on my back. And when I went on my side with sleeping, I mean, the pain was just crazy. Like, you absolutely couldn't sleep there. But then you treated me, like you actually just treated me once, which was probably about a month ago or 6 weeks ago, and I'm totally fine, like 100% fine.
Awesome.
And I don't know if you find that, like I find that this area actually responds really quickly to Prolo normally.
I would say and in your case, it was very acute, right? You know, like you had it and it wasn't something that had gone on for years and years or even months at that point, so it healed very well. Okay. But to your point, like with the pain kind of being more over here, if we look at this model, here's your sternum. And there's so many joints here, right? So there's right here, here's your collarbone. You got the sternoclavicular joint on both sides. And then you have your ribs here that connect to a cartilage piece that then connects to the sternum. So there's not just one joint attachment, right? There's several. And these attachments, there's some at the sternum and then there's some that kind of go over. So people, especially in these lower ribs, can feel the pain more here, not so much center to the chest how we think.
Yep.
This actually shows us really well. All the ribs that are coming around towards the sternum, and then of course the little pieces of cartilage and then bigger pieces of cartilage that anchor it to the sternum. So when somebody has a rib or chest instability, it really could be any or all, right, of those areas. And two, something I just want to mention before we talk about the muscles, I mean, these ribs go all the way back to attach at your thoracic vertebrae. So I think in my practice specifically, I've been seeing a lot more thoracic people, and it's been such a chronic thing that chicken or the egg, maybe we're not sure, but they're having instability on both places. And it's like their whole thorax is like this, I call it a seesaw, right? Kind of working back and forth.
Almost everybody seeing you or me, they'll say that it's progressive. Because I don't know if you ask them this question, but I'm like, John, why did you decide to come now? Because normally the reason is it's just getting crazy. Like it went from a little bit of a problem to a lot of problem.
Yeah. So
you can understand where somebody has a little bit of a thoracic instability, then once this thing gets loose, then it's crazy. It's crazy. So again, we say this often on the videos, is it's a progressive disorder. Yeah. It's like you might have a little bit of a knee pain on the outside, but if it's from instability, the whole knee's eventually going to be unstable. And it's so much easier to treat it earlier,
for sure.
you know, earlier than later.
What also happens when you have instability in this area and as it progresses is all like the muscles that surround the area will actually spasm and tighten because they're trying to provide stability, right? Yeah. So if you think about the ribs, you have muscles right in between each rib, but then you also have these really kind of big powerhouse ab muscles that are attaching at your ribs. So if you've got instability here, people might say like, gosh, I just feel like my abs are cramping, or my abs, like, everything is tight, not because they're like super strong, but it's just because my body is clamping down, trying to hold everything together.
Here, this doesn't show all the muscles, but all your pec muscles, they attach there. Your latissimus dorsi, I mean, that's like, it goes from here all the way here. And that gives you like power. That gives you a lot of arm power. Anything that attaches to the rib, that muscle can lose power. So if somebody just like, you just know something's weak in your arm, something's weak in your abs, something weak in your back, it still could be the chest. I mean, it sounds kind of crazy, but... And then there are times where you don't, with prolotherapy, just treat this. You might actually treat, because people are like, Doc, hey, are there ligaments over here? Why are you treating over there? But again, the back muscles, where do the back muscles attach?
They all attach,
the low back muscles attach on the thoracic spine. The neck muscles attach on the thoracic spine. So, well, basically, then they attach to ribs. So the ribs are a lot of muscle attachments on the ribs.
Absolutely. And if anyone has ever had like a rib that slips out of place or that is unstable, I mean, it hurts like heck. I've had that myself. It is awful. And because all those muscles, like it hurts just to have it out of place. And then when all those muscles clamp down, it's like the worst trigger point you just cannot get to or cannot release. It's terrible.
Yeah.
Related to the ribs, and you and I have done a video on this as well, is the scapula. And it's not like there's this big ligament that attaches the scapula to the ribs necessarily, but it is considered a joint, the scapula over the ribs and how it moves. And if there is a rib instability, it can actually throw off how smoothly that scapula is able to move over it. So we took a video.
You can see all the space here. This is the normal side.
So these are the ribs that are wrapping around, and then here's the shoulder blade.
Yeah, and then there's no space where the scapula on the ribs. So the scapula is actually smashing on the ribs. So it can seem like rib pain, and then anybody can figure out whether the scapula is rubbing on the ribs. They can just go like this, and you actually feel it.
So when somebody comes to us and we know that they have a rib or chest instability, there's several places that we actually inject in order to do a comprehensive treatment to the area. So you can see all these dots here, what they represent is attachments. Okay, joint attachments, ligament attachments, muscle attachments. And so quite commonly, these are all the areas that we would inject when someone has a diffuse rib chest instability. And here's a video actually of that, of me treating a chest here with ultrasound. And
I want to see the fluid going in.
I think this patient too, if I'm not mistaken, I actually had a chest and thoracic issue that we were treating both.
How do you determine that you need the chest and the thoracic versus just the chest done?
That's a good question. So people that come in like complaining of the chest, I'm always going to evaluate the thoracic just because if your ribs are anchoring here and here. And there's a lot of clinical things, like they'll say if their pain wraps around, if they are getting clicking and popping in your thoracic spine, and if we do a DDR, a motion x-ray of the thoracic, and then there is instability showing up. And then here is actually a video of us treating the ribs on the thoracic spine as well. Because nerves lay under our ribs, right? They lay directly under the bone. Patients, if they have a rib or a thoracic instability, or if they have that kind of seesaw, people can get really bad nerve pain, kind of like a pinched nerve that radiates towards their chest too, which it hurts again like heck. And so we have to really get that stability there to get the pressure off the nerve.
When do you inject the nerve? And then what would decide that? Like where you might put PRP around the nerve?
You know, stability is always the number one goal, right? You can put PRP around a nerve all day, but unless you get the smashing off of the nerve, it's not going to do much. If patients get intermittent kind of radiculopathy, like, it comes and goes, I'd be more apt to just focus on getting the stability there. But if it's like a constant, nagging, terrible nerve pain, that's really doesn't really let up, I would be more apt to put PRP on sooner than later.
I've seen on real severe cases that sometimes you use a brace.
Yeah.
Like if somebody, we see some people, like, they barely move and it's click, click, grind, grind, crunch, crunch, like Ehlers-Danlos syndrome.
Yeah.
So
I would say in the majority of cases for chest or even thoracic, any kind of rib instability, I do put people in a brace.
Okay.
For several reasons. One is like this area of our body is breathing all day, right? It's constantly, our rib cages are expanding. So if you have a wrist instability, I could say, hey, let's try not to use that wrist, kind of baby it, but I can't say like, hey, let's not breathe as much. Wearing the brace helps to just kind of support just during everyday breathing. And, majority of people, not everybody, majority of people don't have great posture, so it just kind of helps with a lot of things by bracing.
So thoracic instability or chest instability can affect breathing because then when they take a deep breath, it stretches the ligaments and the rib slips more. So that's not a good situation. Then it reminds me that I've had, in the history, not commonly, but occasionally I have somebody who they felt like they were having a heart attack. So the medical term for slipping rib, the ER doctors will say you have costochondritis. But basically we're talking about the same thing realistically. Yeah. Costochondritis would just be where you have instability in where the rib attaches, like here. So whether it attaches, the rib itself attaches to the cartilage and the cartilage attaches to the sternum. So costochondritis is just that you have really severe pain. Here, slipping rib would be, it's unstable here, so the rib isn't stable.
Yeah,
so it's really
friction.
the same thing. But that's also known as seat syndrome. And there's people, I've had patients who they went to the emergency room because they thought they were having a heart attack. Because even when I had my thing, I could see where somebody, because it's a pain, like it's a dull pain that it's not going away, where you could get nervous. Is there something going on with my heart?
Yeah, absolutely. I had a patient, when you just were talking about breathing recently, who had thoracic instability on her x-ray and thoracic pain, and I treated her, and then the second time she came in, she said, my muscles are more relaxed, I feel like I'm breathing better.
Oh, good.
Yeah, which was exactly awesome, right? Yeah, because if you feel like tight and constricted and you can't breathe, it was great to hear.
Yeah.